Alterations in normal labor. Labor is a normal process. Some women may require interventions such as versions, labor induction, or labor augmentation. Version. When the fetal lie is oblique or transverse, or the presentation is breech, the provider may attempt to turn the baby to a cephalic presentation. Either of two methods may be used: external cephalic version, ECV, and internal version. Each has different indications and technique. ECV is the more common method. Indications. ECV. The goal of ECV is to change the fetal position from a breech, shoulder, transverse lie, or oblique presentation. Successful version allows the woman to avoid cesarean birth by increasing her chance for vaginal birth. Version of a fetus with a transverse lie has a higher success rate than breech presentations. Research has shown that in many cases, spontaneous version occurs by 36 to 37 weeks of gestation. Internal version. Malpresentation in twin gestations is usually managed by cesarean birth, but internal version is sometimes used for the vaginal birth of the second twin. Contraindications. ECV is not done if a woman is unlikely to deliver vaginally, which is the goal of the procedure. Contraindications are similar for internal and external procedures. Maternal conditions that may contraindicate ECV or reduce its success include the following: uterine malformations that limit the room available to perform the version and may be the reason for the abnormal fetal presentation. Previous cesarean birth or other significant uterine surgery is a relative contraindication. Manipulation of the fetus within the uterus may strain and rupture the old incision. Placenta abnormalities, abruption or previa. Manipulation of the fetus within the uterus may cause hemorrhage, endangering both mother and fetus. Third trimester bleeding. Disproportion between fetal size and maternal pelvic size. Fetal conditions that may contraindicate the use of version include the following: multifetal gestation, which reduces the room available in which to turn the fetus or fetuses. Version may be attempted after the first twin is born vaginally in a cephalic presentation. Olighydramnios, ruptured membranes, and a cord around the fetal body or neck, knuckle cord. These conditions limit the room to turn the fetus and may lead to cord compression and fetal hypoxia. Intrauterine growth restriction. Uteroplacental insufficiency. Uterine contractions occurring during the version and labor, insufficiency, and cause fetal compromise. Engagement of the fetal head into the pelvis. Risks. Complications occur in 1% to 2% of attempted versions. Changes to FHR pattern are common, but the pattern usually returns to normal after the version. Serious risks involving the fetus include umbilical cord entanglement, its vessels and resulting in hypoxia, and placental abruption if fetal manipulation disrupts the placental site, leading to fetal compromise and even death. Fetal and maternal blood could become mixed within placental vessels, possibly resulting in maternal sensitization to the fetal blood type. Cesarean birth may be needed for fetal compromise at the time of the version or later if the fetus returns to an abnormal presentation. External cephalic version. ECV is performed at a location and time to allow emergency cesarean delivery if necessary. A non-stress test or BPP is done before the procedure to evaluate fetal health and placental function. If fetal well-being is not present, the version is not performed. An ultrasound examination confirms fetal gestational age and presentation and identifies adequacy of amniotic fluid and placental location. ECV usually is attempted at 37 weeks or longer of gestation, but before the woman is in labor, for the following reasons. The fetus may spontaneously turn to a cephalic presentation before 37 weeks. The fetus is more likely to return to an abnormal presentation if version is attempted before 37 weeks. If fetal compromise and onset of labor occur, fetus born after 37 weeks is not likely to have major problems associated with preterm birth, such as respiratory distress syndrome. The woman often is given a tocolytic to relax the uterus while the version is performed. Epidural or spinal block may be given to reduce the mother's discomfort as the physician manipulates the fetus. Ultrasonography guides fetal manipulations during ECV and monitors the FHR. The physician gently pushes the breech out of the pelvis in a forward or backward roll. Rh immunoglobulin, RhoGAM, is given to the Rh negative woman after external version to prevent Rh sensitization. Labor induction may be done immediately after successful ECV, or the woman may await spontaneous labor or a later induction. EFM is performed for a minimum of 1 hour after the version for evaluation of fetal condition. Internal version. Internal version is an uncommon procedure, most often for the second twin after the first delivers in a cephalic presentation. The physician reaches into the uterus with one hand and with the other hand on the maternal abdomen moves the fetus into a longitudinal lie, cephalic or breech, to allow vaginal birth. Nursing considerations. When caring for the woman having external version, the nurse provides information, assesses the woman and fetus, and helps reduce her anxiety. Provide information. Provider explains the indications and risks for ECV to the woman before she signs an informed consent. Purposes and side effects of any planned tocolytic drug are reviewed. If epidural or other analgesia is planned, its purposes and side effects are explained by the person who will administer the treatment, and the woman signs additional consents. The nurse verifies the woman's understanding of the purposes, risks, and limitations of the procedure and related treatments. Because cesarean birth may be required suddenly, permits to allow the surgery and initial care of her newborn are signed. Promote maternal and fetal health. Admission information is collected as if the woman were in labor or having a cesarean birth, because the need for operative intervention may arise suddenly. The woman should have nothing by mouth 8 hours before and during this short procedure in case a cesarean is needed quickly. An IV line is placed for possible drug administration or fluid resuscitation. Obtain maternal vital signs and baseline FHR values to establish well-being. Abnormal, category 2 or 3, FHR patterns should be reported promptly. Administer the tocolytic medication as ordered. Real-time ultrasonography is used to guide the version and check the FHR periodically during the procedure. The mother and fetus are observed for at least 1 hour after the procedure for return of vital signs to baseline values. Fetal bradycardia may occur during the procedure, but the FHR usually returns to normal when manipulation ends. Reassuring fetal signs are a heart rate within the same range as on admission, resolution of any bradycardia, and the presence of moderate variability in FHR accelerations. Maternal vital signs are taken every 15 to 30 minutes until they return to baseline. The pulse rate should be no higher than 120 BPM. Discomfort should diminish quickly after the version, regardless of whether fetal position changes are successful. Persistent and continuous pain suggests a complication such as placental abruption. If epidural or spinal analgesia was used and is now discontinued, observe for return of sensitization before ambulation. Accompany the woman while ambulating until she is steady on her feet. Regular contractions suggest onset of labor. SROM sometimes occurs, with leakage of fluid from the mother's vagina. Rh immunoglobulin is given if indicated. The IV line is discontinued after the maternal and fetal conditions return to normal, unless labor will be induced the same day. Because the woman having ECV is near term, the nurse should review the signs of true labor and membrane rupture with her and explain guidelines for returning to the hospital if she will be discharged. Anxiety. The woman may be anxious before version because its success is not certain. Complications may require emergency cesarean delivery. She still may be anxious because the fetus can return to its previous position and vaginal birth is not certain. The nurse should keep the woman informed about what is occurring during the version to reduce her fear of the unknown. The nurse can point out reassuring fetal monitor patterns such as normal rate and rate accelerations to help reduce anxiety about the baby. If a problem such as bradycardia develops, the nurse should explain what has happened, what steps are being done to relieve it, and the result of these interventions. Induction and augmentation of labor. Induction and augmentation of labor use artificial methods to stimulate uterine contractions. Techniques and nursing care are similar for both induction and augmentation. Induction of labor is a common procedure in intrapartum units. Induction rates more than doubled from 1990 to 2010, reaching an all-time high of 23.8%. Data from the National Vital Statistics System shows that after nearly 20 years of steady increases, the rate is declining, as seen in the 2015 induction rate of 23.9. Inductions have been associated with a higher cesarean birth rate. This increased risk for cesarean sections can be mitigated if the cervix is dilated at least 2 centimeters and somewhat effaced before labor. Induction is more likely to be successful at term because pre-labor cervical changes favor dilation. In 2014, the cesarean rate was 32.2% for women of all racial origins, which was 2% lower than the rate in 2013. This decline is partly attributed to the focus on reducing non-medically indicated elective cesarean sections and induction of labor before 39 weeks. Indications. Induction of labor may be medically necessary for an obstetric, fetal, or other medical indication, or it may be elective, i.e., performed at the convenience of the patient and/or provider. Labor induction is not done if the fetus must be delivered more quickly than the process permits, in which case a cesarean birth is performed. Induction is indicated in the following conditions. The intrauterine environment is hostile to fetal well-being, e.g. intrauterine fetal growth restriction, isoimmunization, maternal fetal blood incompatibility, and oligohydramnios. Postpartum at or near term without onset of labor, also called premature rupture of membranes, PROM. Pregnancy is preterm, less than 37 weeks. Term preterm premature rupture of membranes, PPROM, is used. Post-term pregnancy. Chorioamnionitis, infection and inflammation of the amniotic sac. Hypertension associated with pregnancy or chronic hypertension, both of which are associated with reduced placental blood flow. Placental abruption. Large abruptions require immediate delivery. Maternal medical conditions that worsen with continuation of the pregnancy, e.g. diabetes, hypertension, renal disease, pulmonary disease, heart disease, antiphospholipid syndrome. Fetal demise. Induction solely for convenience is not recommended. Factors such as having a history of rapid labor and living a long distance from the hospital may be valid reasons to induce labor because of the real possibility that the baby would be born in uncontrolled circumstances. Elective inductions have two major risks: twofold increase in cesarean section compared with spontaneous labor and increased risk for neonatal respiratory complications. Therefore, confirmation of fetal gestational age is paramount before elective induction. Recent recommendations suggest waiting until 40 to 41 weeks before considering elective induction. This gestational age is associated with decreased risk for cesarean delivery and neonatal respiratory morbidity. Prenatal testing sometimes identifies a fetal anomaly that will require specialized neonatal care at a distant facility. The mother may be transported to that facility for labor induction or cesarean birth. Augmentation of labor with oxytocin is considered when labor has begun spontaneously but progress has slowed or stopped, even if contractions seem to be adequate. Non-pharmacologic augmentation may be possible with nipple stimulation. Contraindications. Any contraindication for labor and vaginal birth is a contraindication to induction or augmentation of labor. Possible contraindications and cautions associated with induction may include the following: placenta previa, placental implantation in the lower uterine segment, which could result in hemorrhage during labor. vasa previa, a velamentous insertion of the umbilical cord vessels branch over the amniotic membrane rather than inserting into the placenta, therefore lacking protection of Wharton's jelly. These vessels cross the cervical os. Fetal hemorrhage is a possibility if the membranes rupture. Umbilical cord prolapse, because immediate cesarean is indicated to stop cord compression. Abnormal fetal presentation, for which vaginal birth is often more hazardous, i.e. transverse fetal lie. Active genital herpes. Previous uterine surgery, such as previous classical cesarean incision or myomectomy, removal of uterine fibroids that entered the endometrial cavity. Other maternal or fetal conditions are not contraindications to induction, but require individual evaluation, such as the following. One or more previous low transverse cesarean deliveries. Breech presentation. Condition in which the uterus is overdistended, such as a multifetal pregnancy and polyhydramnios, because the risk for uterine rupture is higher. Severe maternal conditions such as heart disease and severe hypertension. Fetal presenting part above the pelvic inlet, which may be associated with cephalopelvic disproportion or a preterm fetus. Inability to adequately monitor the fetal status during labor or presence of indeterminate or abnormal FHR. Risks. Induction and augmentation of labor, like spontaneous labor, are associated with following risks. Excessive UA, increased frequency, duration, or insufficient relaxation time or resting tone. Can reduce placental perfusion and fetal oxygenation. Uterine tachysystole may or may not be accompanied by an indeterminate or abnormal FHR pattern. Uterine rupture may occur, which is more likely with overdistension of the uterus with excess amniotic fluid or a multifetal pregnancy or in case of excessive UA. Water intoxication can occur, which is more likely if a hypotonic IV solution is used to dilute the oxytocin with rates greater than 20 milliunits per minute. Chorioamnionitis and cesarean birth. Postpartum hemorrhage. Elective labor induction at term is associated with increased risk for cesarean birth and newborn respiratory problems. Studies have demonstrated that nulliparous women who have their labor induced are 2 to 3 times more likely to have a surgical birth. A Bishop score, table 15.2, of 7 or less is associated with an increased risk for cesarean birth compared with spontaneously laboring patients. The risk for cesarean after failed induction was similar whether women had medical or elective inductions. Risk for chorioamnionitis increases as the duration of ruptured membranes increases. Technique. Pharmacologic and mechanical methods may be used for labor induction and augmentation. Cervical assessment estimates whether the cervix is favorable for induction. The Bishop scoring system is used to estimate cervical readiness for labor with 5 factors: cervical dilation, effacement, consistency, position, and fetal station. Vaginal birth is more likely to result if a Bishop score is higher than 8. Cervical ripening. Cervical ripening is a process used to ripen, soften, the cervix and make it more likely to dilate with the forces of labor. Typically, this procedure is performed before the scheduled induction. Cervical ripening is recommended for a Bishop score of 4 or less. Pharmacologic methods. Prostaglandin is a drug that may be used to cause cervical ripening. Prostaglandin E2, PGE2, preparations may be given as an intravaginal gel, an intracervical gel, or a timed-release vaginal insert. PGE2 preparations are administered in a setting where fetal monitoring and emergency care, including immediate cesarean birth, are readily available. Soprostol, Cytotec, is a prostaglandin E1 analog, usually given for gastric ulcers. Misoprostol can be used for both cervical ripening and induction of labor. Misoprostol for cervical ripening is currently in off-label use, and its manufacturer does not plan to seek U.S. FDA approval for these purposes. In addition to its effectiveness, misoprostol is attractive for its lower cost and stability at room temperature. However, it should not be given to a woman who has had a previous cesarean birth or major uterine surgery. Misoprostol is available in 100 and 200 microgram tablets. The usual dose is 25 or 50 micrograms vaginally, 1/4 or 1/2 of an unscored 100 microgram tablet. A pharmacist should prepare the tablet to ensure dose accuracy when using an unscored tablet. The 25 microgram preparation of misoprostol is placed high in the vagina. An oral dose of misoprostol, 100 micrograms, has also been reported to be effective. Because of the major adverse effect of prostaglandins in tachysystole, the drug is administered in a setting in which fetal monitoring and emergency care, including cesarean birth, are immediately available. After vaginal insertion of prostaglandins, the patient should remain recumbent for at least 30 minutes. The FHR and UA should be monitored continuously for a period of 30 minutes to 2 hours. Mechanical methods. Mechanical methods for cervical ripening are efficacious and have decreased risk for excessive UA. These methods include placement of a transcervical balloon catheter, membrane stripping, or placement of hydroscopic inserts, i.e. laminaria, sterile cone-shaped preparations of dried seaweed. Transcervical catheters are placed through the internal cervical os, and downward tension is created by either taping the catheter to the thigh or attaching the catheter to a dependent IV bag. Membrane stripping is the digital separation of the amniotic membrane from the wall of the cervix and the lower uterine segment. Spontaneous labor may occur within 48 hours and reduces the need for other induction methods. Hydroscopic inserts, laminaria, are placed into the cervical canal, where they absorb water and swell, gradually dilating the cervix. Placement requires a speculum and can be cumbersome and uncomfortable. Oxytocin administration. Oxytocin is the most common drug given for induction and augmentation of labor. Oxytocin is a powerful drug, and predicting a woman's response to it is impossible. Several precautions reduce the chances of adverse reactions in the mother and fetus. Oxytocin is diluted in an isotonic solution and given as a secondary, piggyback, infusion so it can be stopped quickly if complications develop. The oxytocin line is inserted into the primary, non-additive or maintenance IV line as close as possible to the venipuncture site, the proximal port, to limit the amount of drug infused if discontinued. Oxytocin is started slowly, increased gradually, and regulated with an infusion pump. The primary line is also regulated with an infusion pump. UA, FHR, and fetal heart patterns are monitored before induction for a baseline, when oxytocin is started, and throughout labor. Oxytocin receptor sites become desensitized from prolonged exposure. Continual rate increases can result in abnormal UA, tachysystole, coupling or tripling of contractions, or low-intensity contractions. The rate of oxytocin infusion may be gradually reduced once the active phase of labor is reached, 4 to 6 centimeters of cervical dilation, to decrease the receptor site saturation. It may be stopped or the rate reduced after the patient's membranes rupture. When labor is augmented with oxytocin, a lower total dose usually is needed to achieve adequate contractions compared to the dose needed for labor induction. Nursing considerations. When providing care during cervical ripening and labor induction or augmentation, the nurse observes the woman and fetus for complications and takes corrective actions if abnormalities are noted. The nurse has a great responsibility when administering uterine stimulants to a pregnant woman. The nurse decides when to start, change, and stop an oxytocin infusion using the facility's protocol and medical orders. Facility policies related to oxytocin must clearly support correct nursing and medical actions. Observe the fetal response. Oxytocin stimulates uterine contractions, and they may become too frequent, tachysystole. Tachysystole may reduce placental blood flow, utero-placental insufficiency, which decreases exchange of fetal oxygen and waste products. Before induction and augmentation of labor, the nurse assesses the FHR and contraction pattern to ensure fetal well-being is present. ACOG and AHWAN set forth standards for FHR assessment based on risk stratification of the patient. Individual facilities set documentation guidelines incorporating those recommendations. The nurse remains alert for FHR patterns that suggest reduced placental exchange secondary to excessive UA. Examples are fetal bradycardia, tachycardia, pathologic decelerations, and decreased FHR variability. The nurse should assess the woman and fetus carefully to identify the most likely cause of the problem and institute corrective actions. See Chapter 14 for more detailed information on fetal monitoring. If indeterminate or abnormal patterns occur with tachysystole, the nurse takes the following steps to reduce UA and increase fetal oxygenation. The oxytocin infusion and administer a bolus of at least 500 milliliters of the primary non-additive infusion. Keep the woman in a side-lying position to prevent aortic cable compression and increase placental blood flow. Consider oxygen administration at 10 liters per minute via non-rebreather face mask until FHR pattern improves. The provider. Anticipate order for terbutaline, breathine, a smooth muscle relaxant, 0.25 milligrams subcutaneously, if no improvement with other interventions. Oxytocin may be restarted when the tachysystole resolves and the FHR pattern returns to normal. The oxytocin should be restarted at no more than half the previous rate if it has been turned off for less than 20 to 30 minutes. If more than 30 to 40 minutes have elapsed, it should be restarted at the initial dose. Observe the mother's response. The uterus must be assessed for excessive UA that may reduce fetal oxygenation and contribute to uterine rupture. Contractions are assessed for frequency, duration, and intensity, uterine resting tone, and relaxation time of at least 60 seconds between contractions in first stage labor and 45 to 50 seconds in second stage labor. UA observations are charted at the same intervals as the FHR. Corrective actions for excessive UA with normal FHR patterns include positioning the woman on her side and administering an IV fluid bolus of at least 500 milliliters. If the tachysystole does not resolve in 10 to 15 minutes, the oxytocin infusion rate should be decreased by half. If tachysystole persists after another 10 to 15 minutes, the oxytocin infusion should be stopped until the UA is normal. Provided that the FHR pattern has remained normal, the oxytocin infusion may be restarted as described previously in the discussion of the fetal response. If the oxytocin must be discontinued, the medical decision about resuming is individualized. The oxytocin infusion may be restarted at the same or a lower dose if the contractions are no longer too frequent and the FHR is reassuring. If the oxytocin has been discontinued for 40 minutes or longer, the drug that was in the woman's system has been metabolized. Therefore, it should be restarted at the beginning dose ordered and advanced more slowly to prevent a recurrence of uterine tachysystole and indeterminate or abnormal FHR patterns. The woman's blood pressure and pulse rate are taken every 30 minutes or with each oxytocin dose increase to identify changes from the baseline. Her temperature is assessed every 2 hours, unless ruptured, and then it is assessed hourly to identify infection. The woman may need to use pharmacologic and non-pharmacologic pain management techniques sooner than in a spontaneous labor. Although the goal of induced and augmented labor is to mimic natural labor, stimulated contractions often increase in intensity more quickly. Cervical ripening may increase the discomfort felt by the woman. Recording intake and output identifies fluid retention, which may precede water intoxication. Signs and symptoms of water intoxication include headache, blurred vision, behavioral changes, increased blood pressure, and respirations, decreased pulse rate, auscultatory crackles and wheezing, and coughing. After birth, the mother is observed for postpartum hemorrhage caused by uterine relaxation. Postpartum uterine atony is more likely if she had prolonged use of oxytocin. The uterine muscle becomes fatigued and does not contract effectively to compress vessels at the placental site, and the oxytocin receptor sites may be saturated and less responsive. Atony is manifested by a soft uterine fundus and excess amounts of lochia, usually with large clots. Hypovolemic shock may occur with hemorrhage. Nursing care, preparation and birth. Responsibilities during birth. The nurse's responsibilities during birth may include the following: preparation of a delivery table with sterile gloves, gown, drapes, solutions, and instruments. Perineal cleansing preparation. Ongoing assessments of woman and fetus. Supporting the woman and partner with final pushing efforts. Initial care and assessment of the newborn. Administration of medications, usually oxytocin, to contract the uterus and control blood loss. A nurse or resuscitation team from the nursery is usually present if the newborn is at risk for problems such as respiratory depression and if problems occurred during labor. A person certified to provide neonatal resuscitation should be present at all births. Personal protective equipment, including eye shields, should be worn as protection from fluid splashing and blood spurting. The newborn is covered with blood, amniotic fluid, vernix, and other body substances. The bath usually occurs several hours after birth, so persons involved in infant care should wear gloves and other needed protective equipment to avoid contact with potentially infectious secretions. Operative vaginal birth. Operative vaginal birth, also called forceps or vacuum extraction, may be used by the provider to apply traction to or assist descent of or rotation of the fetal head during birth, aiding the woman's expulsive efforts. As the rate of cesarean births has increased, vaginal births assisted by either forceps or vacuum extractor have declined. Among vaginal births in 2013, 3.3% were delivered with instrumentation, with 0.59% of the women delivered with forceps and 2.72% with vacuum extraction. Use of either method is down from 9.01% in 1990. A vacuum extractor uses suction to grasp the fetal head while traction is applied. Its use is similar to that of forceps and carries the following contraindications to use: breech, face, or brow presentation, cephalopelvic disproportion, unengaged fetal head, incompletely dilated cervix, suspected bone demineralization condition, i.e. osteogenesis imperfecta, bleeding disorder, i.e. hemophilia, von Willebrand's disease, or premature infant. The fetus of 34 weeks or less of gestation is more likely to injure the head, scalp, and intracranial vessels from vacuum suction. No more than 3 pop-offs of the vacuum extractor should be allowed. They should not be followed by attempts to deliver with forceps. Forceps are curved metal instruments with 2 curved blades that can be locked in the center. Many styles are available for different needs. The blades may be closed or open and are shaped to grasp the fetal head. Foam pads are available to cushion the fetal head from the blades. Piper forceps are a special type used to assist birth of the head, as it is born last in a vaginal breech birth. Forceps and a vacuum extractor also may be used during cesarean birth if assistance is needed in delivering the head. Indications. Forceps or vacuum extraction is considered if the second stage should be shortened for the well-being of the woman, fetus, or both, and if vaginal birth can be accomplished quickly without undue trauma. Maternal indications may include exhaustion, inability to push effectively, infection, and cardiac or pulmonary disease. Fetal indications may include failure of the fetal presenting part to fully rotate and descend in the pelvis, partial separation of the placenta or abnormal FHR patterns near the time of birth. Contraindications. Cesarean birth is preferable if the maternal and fetal conditions mandate a more rapid birth than can be accomplished with forceps or vacuum extraction, or if the procedure would be too traumatic. Examples of these conditions are severe fetal compromise, acute maternal conditions such as congestive heart failure and pulmonary edema, a high fetal station, a disproportion between the size of the fetus and maternal pelvis. The main risk in forceps and vacuum extraction is trauma to maternal and fetal tissues. Because of the relative safety of cesarean birth, the attempt at an instrumental birth usually is abandoned if the fetal head does not descend easily. Maternal risks include laceration, hematoma of the vagina, pelvic floor disorders, and sphincter disruption and infection. The infant may have ecchymosis, facial and scalp lacerations and abrasions, facial nerve injury, cephalohematoma, subgaleal hemorrhage, and intracranial hemorrhage. The vacuum extractor may create scalp edema called a chigon at the application area. Technique. Preparation for vacuum extraction or forceps is similar to that for any vaginal birth. The presentation, position, and station of the fetal presenting part are verified. Membranes must be ruptured and the cervix completely dilated for forceps or vacuum extraction birth. The woman needs adequate anesthesia, usually a regional block such as an epidural. Forceps and vacuum extractor assisted births are classified according to the extent of descent of the fetal head into the pelvis during the procedure and necessary degree of rotation for the fetal head to be born. Describing descent in centimeters below the ischial spines is preferred. Outlet operative vaginal delivery. The fetal head is at or on the perineum, with the scalp visible at the vaginal opening without separating the labia. The position is either right or left occiput anterior, ROA, LOA, or left occiput posterior, ROP, LOP. Low operative vaginal delivery. The leading edge of the fetal skull is at station plus 2 centimeters or lower and not on the pelvic floor. Low operative vaginal birth is subdivided according to the amount of rotation of the fetal head needed. Births requiring 45 degrees or less of fetal head rotation are simpler. Mid-pelvis operative vaginal delivery. The leading edge of the fetal skull is between 0 at the level of the ischial spines are engaged and plus 2 centimeter station. The physician determines the presentation, position, and station of the fetal head and amount of cervical dilation. When the blades are correctly applied, the long axis of the blades lies over the fetal cheeks and parietal bones. After checking for proper application, the physician locks the 2 blades in the center and pulls gently as the woman pushes, following the curve of the pelvis. An episiotomy, surgical incision of the perineum, may be performed as the fetal head distends the perineum. The physician may keep the forceps on until the head is born or may remove the blades just before expulsion. The rest of the fetus is born in the usual way. For vacuum extraction, a hand pump is used to create suction to hold a vacuum cup on the fetal head in the midline of the occiput. The physician applies traction intermittently, as in a forceps-assisted birth. A vacuum release allows easy removal of the cup. Hospital policies usually limit to 3 the number of times the vacuum cup can be applied. Nursing considerations. When a forceps or vacuum extraction birth is anticipated, a catheter is often added to the instrument table for the birth to empty the bladder before the procedure. The physician specifies the type of vacuum cup or forceps. The nurse must apply the suction to the cup. Suction should not go outside the green zone on the suction indicator. Should be assessed and any rate lower than 100 BPM reported. After birth, the mother and infant are observed for trauma. The mother may have vaginal wall lacerations or hematoma. Cold applications for the first 12 hours reduce pain by numbing the area and limit bruising and edema of the tissues. Heat applications after 12 hours aid resolution of the edema and bruising. The infant often has reddening and mild bruising of the skin where the forceps were applied. These areas do not need treatment. Cold treatment is not done for an infant because of hypothermia. Skin breaks that allow entry of microorganisms should be noted and kept clean. Facial asymmetry, which is most obvious when the infant cries, suggests facial nerve injury. Temporary caput or scalp edema is common at the location of the vacuum extractor cup. After a forceps birth, the parent may ask why the baby's cheeks are reddened or bruised. A good response is to explain that the pressure of the forceps on the baby's delicate skin may cause minor bruising that usually resolves without treatment. Point out improvement in the area during the postpartum stay. Parents may need an explanation for the scalp edema or chignon after a vaginal birth assisted with a vacuum extractor. Episiotomy. Episiotomy, or incision of the perineum just before birth, was once routine for vaginal births. Incidence has remarkably decreased over the past 30 years. The presumed maternal benefits of reducing pain, perineal tearing, and later pelvic relaxation with incontinence have not proved true. However, the birth attendant must decide if one is needed, and indications are not always clear. Indications. Examples of situations in which the birth attendant may perform an episiotomy are as follows. Rapid resolution of fetal shoulder dystocia, in which the shoulder of a fetus becomes lodged under the mother's symphysis during birth. Vacuum extractor assisted or forceps assisted births. Birth with the fetus in an occiput posterior face up position. Breech delivery. Macrosomic fetus. Risks. Is the main risk in episiotomy. Perineal pain occurs with both episiotomy and spontaneous tears. However, perineal pain may last longer with episiotomy, mainly because of its tendency to extend into deeper lacerations. Prolonged perineal pain impairs resumption of sexual intercourse and makes it uncomfortable for the woman. Data since the 1980s have confirmed that midline episiotomies, more frequently done than mediolateral episiotomies, increase a woman's risk for the more extensive third degree into the anal sphincter, or fourth degree through the rectal sphincter tear. Fecal incontinence was increased fourfold to sixfold compared with women who delivered with an intact perineum. Spontaneous lacerations are more likely to occur if a woman had an episiotomy with a previous pregnancy. However, despite data confirming maternal benefits of avoiding episiotomies, approximately 12% of vaginal deliveries have routine episiotomies performed. Technique. An episiotomy is done when the fetal presenting part has crown to a diameter of approximately 3 to 4 centimeters. The two types of episiotomies, median, midline, and mediolateral, have different advantages and disadvantages. Nursing considerations. An episiotomy sometimes can be avoided or limited in length with nursing measures. An upright position while pushing promotes gradual stretching of the woman's perineum. Pushing until the urge is felt also gradually distends the soft tissue of the pelvic floor. Pushing with an open glottis technique rather than prolonged breath holding when pushing also promotes gradual perineal stretching. Daily perineal massage and stretching by the woman from 36 weeks until birth has been shown to reduce risk for perineal trauma during birth. Women older than 30 years having their first baby and adhering to the daily 10-minute perineal massage showed greatest benefit. Nursing interventions during the recovery and postpartum periods are similar for episiotomy and perineal laceration. The perineum should be observed for hematoma and edema. As with use of forceps, perineal cold applications are done for at least the first 12 hours, followed by perineal heat applications after 12 hours. Birth. In 1965, the cesarean birth rate in the United States was approximately 5% of all births, rising to almost 21% in 1996, when the percentage dropped slightly. From 1996 to 2009, the number of cesareans steadily increased among all maternal age group, with a peak in 2009 of 32.9%. Data for 2015 show that cesarean deliveries have continued the steady downward trend started in 2010, with the current rate being 31.8% of all births. Many factors contribute to the rise in the national cesarean birth rate, including the following. Women having their first baby are more likely to deliver by cesarean than women who have had one or more previous births vaginally. Women having labor induction with their first baby have a greater risk for a cesarean. 26% primary first cesarean rate adds to the overall rate because more women will have repeat cesareans rather than attempting vaginal birth for subsequent children. Women are having children later, and cesareans are more common in the older pregnant woman. Increasing maternal body mass index. Cesarean birth may be chosen if the baby remains in a breech presentation. Threat of litigation if birth outcomes are not good causes physicians to opt for surgery quickly if the maternal or fetal condition or both seem to be at risk. Cesarean on maternal request rather than medical need. Evidence linking labor induction to increased risk for cesarean birth continues to accumulate. Studies have demonstrated that women who have their labor induced are 2 or 3 times more likely to have a surgical birth. Women having a Bishop score of less than 6 at the time of induction, indicating a cervix that is not favorable, had a greater risk for cesarean than women who had a score of 8 or more. The likelihood of a cesarean increases as the duration of induced labor increases. The risk for cesarean after failed induction was similar whether women had medical or elective inductions. A national goal for the Healthy People 2020 initiative is to reduce the rate of first-time cesarean births in low-risk women to no more than 23.9% using a baseline of 27.4% of births in 2007. Reducing repeat cesareans to 81.7% from the 2007 baseline of 90.8% of births to low-risk women, second goal for cesarean births. Promotion of vaginal birth after cesarean, VBAC, in women for whom it is appropriate is a major way to accomplish these goals. Other possibilities include more careful evaluation of dystocia of labor, difficult or prolonged labor, as a reason for cesarean and careful selection of women who are appropriate candidates for vaginal breech birth. ECV may be an option to attempt to change the presentation of a near-term fetus in the breech presentation to a cephalic presentation. Vaginal birth after cesarean. With the high cesarean rate and the desire to lower the incidence, the decision about whether to have a trial of labor after a cesarean, TOLAC, hopefully resulting in a VBAC, has never been more difficult than now. At one time, the dictum, once a cesarean, always a cesarean, was accepted without question. For many years after this dictum, having no research backup, the only women who had VBACs were those who entered the hospital in such advanced labor that there was no time for a repeat cesarean. Current literature states VBAC is associated with decreased maternal morbidity and decreased risk for complications in future pregnancies. Yet a failed TOLAC is associated with more complications than a repeat cesarean. As low transverse uterine incisions become the norm for almost all women having cesarean births, the safety of a trial of labor became established. VBAC gradually became an accepted way to lower the rise in cesarean births. Research continues on the safety of VBAC.